if you're listening to this right now, I'm going to make a bet.
Oh, yeah.
Yeah. There's a very, very good chance your brain is completely at capacity. You're probably, like, drowning in flashcards.
Respiratory acidosis versus alkalosis.
Exactly. Or you're frantically cramming the side effects of beta blockers before your next clinical rotation.
It's the nursing school survival mode. We definitely know that feeling.
We absolutely do.
Yeah.
So, to the nursing students listening, we see you. We know the sheer volume of science you have to absorb is, well, it's crushing. But we're going to take a little break from the pharmacology for a few minutes.
Okay.
Because the source material we're diving into today suggests that the hardest part of becoming a nurse isn't actually the science.
Which sounds completely counterintuitive when you're staring at a physiology textbook at 2 in the morning.
Right. But the argument here is that the biggest challenge, it isn't memorizing the drugs.
Yeah.
It's the fact that you are effectively immigrating to a foreign country.
A foreign country is the perfect analogy. We're looking at a deep dive into intercultural communication in healthcare, and specifically Chapter 5 of this foundational text on health communication.
And the premise is what now?
The core idea is just fascinating. Healthcare isn't just a job sector. It is a distinct culture. I mean, it has its own language, its own rituals, its own hierarchy.
A dress code.
Its own set of values, absolutely.
So if I'm understanding this right, the argument is that nursing school is basically a really intense multi-year citizenship test.
That is the perfect way to frame it. You are undergoing a process of acculturation. You're learning to be part of this specific tribe.
Okay.
And the dangerous part, and this is the part we really need to unpack today because it affects how you do your job, is that as you become a citizen of healthcare, you are, naturally drifting further away from the very people you want to help.
The patients.
Exactly. As you become an insider, the patient. They become the outsider. The patient becomes the foreigner.
Okay, let's stick with this foreign land analogy for a bit, because I think it really helps explain why patients can act the way they do. The text says that if you go to, say, Italy or Japan and you don't speak the language, you feel isolated.
Insecure.
Insecure, yeah. You feel stupid because you don't know the rules.
And that is exactly the emotional state of a patient walking into a hospital. But let's look at why that wall even exists. The most obvious barrier is language.
Medicalese.
Yes. And I know what you're thinking. Every job has jargon. Mechanics have it, coders have it.
Sure.
But the text makes a really interesting distinction here. Healthcare and law are pretty much the only professions where you have to learn an entire separate language just to function. It's a requirement for membership.
The source lists some of these terms, things like appendicitis, aneurysm, myocardial infarction.
Lobectomy.
Yeah.
Now, pause for a second. To you, the nursing student, those words are tools. They're comforting in a way because they're so precise. They describe anatomical realities efficiently.
Right. If I just say he's having a heart attack, that's kind of vague. If I say ST elevation myocardial infarction, that tells the whole team exactly what to do.
Correct. But now flip the script. To a patient, those are just scary alien sounds. They represent a threat. When you say lobectomy, you're thinking about a surgical procedure. The patient is hearing, someone is going to cut a piece of me out.
Wow.
The text argues that this language gap creates immediate isolation. You're speaking the language of the tribe, and the patient is just left wondering what on earth is happening to their own body.
So it creates a power dynamic, like instantly. I know the words, you don't.
It does. And it's not just the words, it's the artifacts. I love that the text calls them that, like we're studying some ancient civilization.
It's anthropology. We're talking about the visual cues, scrubs.
White coats, stethoscopes draped just so around the neck.
Sterile gloves, even just the smell of the hospital.
Think about it. These are things you stop noticing after just a few weeks of clinicals. They just become your work clothes.
They're just what you wear so you don't get bodily fluids on your jeans.
To you, yes. But to the outsider, these are symbols of authority. They signal, I belong here. I know how this machine works. You do not. They reinforce that us versus them dynamic before you even open your mouth.
The text mentions a specific ritual that really cements this. The white coat ceremony. Most nursing and medical schools have this now. You get your little short white coat, you take an oath.
Right.
It feels like a graduation, but it's actually at the beginning.
It's a rite of passage. In anthropology terms, it's an initiation ritual. It is the tribe formally accepting you and saying, you are one of us now.
You're adopting a new identity.
You are. You're shedding your civilian skin and putting on the uniform of the provider.
And once you put that coat on, you have to start thinking differently.
Yeah.
You can't function in a hospital if you think like a civilian.
You have to compartmentalize. But that brings us to a really interesting conflict within the culture itself. Because healthcare isn't just one big happy family. There are co-cultures.
The tribes within the tribe. So you've got the MDs, the RNs, the PAs, the techs. And the text points out that these groups don't always value the same things.
This is critical for nursing students to understand, especially when you feel that frustration during your clinicals. The source makes a really sharp distinction between biomedical-centric education and biopsychosocial education.
Okay, let's break those down.
Yeah.
Biomedical-centric is the classic medical school model, right?
Yeah.
The focus on the disease.
Generally, yes. The text argues that physician training has historically focused on the disease itself, the cure, the biological mechanism, it's very objective, fix the broken part.
And the nursing model.
Nursing education is defined as biopsychosocial. It focuses on the patient as a whole person, their biology, sure, but also their psychology and their social environment.
So the doctor comes in and sees a myocardial infarction that needs a stent. But the nurse comes in and sees a terrified father of 3 who's worried about losing his job because he can't lift boxes anymore.
That is the stereotypical divide, yes. And while the text notes that things are shifting toward a more collaborative team approach, that tension still exists. It causes what's called intercultural conflict. So you might be fighting for the patient's comfort or their understanding, while another provider is solely focused on the clinical data.
So not only are you navigating a foreign country, but your fellow citizens are speaking different dialects.
Precisely. And while you're navigating all that internal politics, you're dealing with the patient who is completely baffled by all of it.
This section on the patient as the other really struck me. We talked about language, but the cultural clash goes deeper. It's about behavior. The text uses some fancy terms: haptics, proxemics, and kinesics.
Touch, space, and movement. Think about what we ask you to do as a nursing student. We train you to walk into a stranger's room and immediately touch their most private areas.
Stick needles in people.
We ask these incredibly intimate questions about bodily functions.
And we tell you to do it with emotional restraint.
Right. You have to be efficient. You have to gather data. You can't break down crying every time a patient gets a bad diagnosis.
But flip that perspective. To a patient who is part of the larger American culture, that efficiency looks like coldness. That emotional restraint looks like you don't care.
And that's the tragedy of it. You are being efficient because you want to help them. But the very tool you use to help them makes them feel like you're egocentric.
Egocentric is a strong word.
The text uses it to mean that the system is centered on the provider's needs, not the patient's. The provider focuses on the disease. The patient is focused on themselves. It creates this massive disconnect.
And there's a power dynamic here we can't ignore.
A huge one.
In the real world, the civilian culture, if you pay for a service, you're the boss. The customer is always right.
But in the hospital?
In the hospital, the illness is the focus. The patient loses their autonomy. They're told when to eat, when to sleep, what to wear.
Plus, you have all the legal requirements, privacy laws, fear of malpractice, that force providers to guard their words. So you have a patient who desperately wants connection and a provider who is legally and professionally trained to maintain distance.
And this leads us to what I think is the most important concept for a student to grasp about the patient's mind.
Identity.
Yeah.
Identity.
This is where we get into the psychology of being a patient. The text references Kathy Charmas's work on identity levels.
And it starts with a simple contrast. You, the nursing student, you chose to join this culture. It's an achievement. You worked hard to get here.
Correct. But the patient, their entry into this culture is usually a trauma. Their identity is being impacted by injury. They did not sign up for this. And because of that, they go through these really specific identity shifts.
Let's walk through these 4 responses to illness, because I think recognizing these can save a student so much frustration when they're dealing with a patient who just seems difficult.
Okay.
The first one is the supernormal identity. This is denial, essentially. The patient refuses to let the illness change them. They try to do everything they did before. They might try to discharge themselves early or ignore dietary restrictions.
They're trying to prove they're still the same person.
Exactly.
So when a nurse sees a non-compliant patient, the guy who tries to walk to the bathroom on a broken hip, they might actually just be seeing someone in that supernormal phase.
Exactly. They aren't trying to be difficult for the sake of it. They are fighting to protect their old identity. Then you have the second stage. the restored identity.
That's where they're a little less optimistic, right?
A little. They think, okay, I'm sick now, but I will get back to 100%.
Yeah.
They view the illness as temporary. They haven't accepted that a permanent change might have happened. They're just waiting for the cure.
And then comes the hard reality, the contingent personal identity.
This is the aha moment. But it's a painful one. They realize, I can't do what I used to do. Things are different now. The new reality sets in.
So they might seem depressed or withdrawn here.
Because they are grieving their old self. And finally, you get to the goal, the salvaged self.
Acceptance.
Yes, acceptance. They integrate the illness into a new version of their identity. I have a person with diabetes, and that's a part of who I am, but I am still me. They have salvaged their sense of self despite the illness.
This is so helpful because in nursing school, you learn about disease progression, stage 1 cancer, stage 2. But nobody really teaches you the identity progression.
And if you misinterpret where a patient is in that progression, communication just fails. You can't talk to a supernormal patient about long-term lifestyle changes. They're not listening yet. You can't talk to a contingent personal patient with false cheerfulness. You have to meet them where they are emotionally.
Okay, we have to talk about the elephant in the room, or maybe the pyramid in the room.
Mhm.
We've talked about language and psychology, but we can't talk about the culture of U.S. healthcare without talking about money.
The economic barrier, this is huge.
The text outlines a tiered access pyramid, and honestly, it is brutal.
It is. Culture isn't just language and rituals, it's socioeconomic status. The text breaks it down to 4 tiers. At the top, you have the wealthy,
Cash pairs, concierge medicine.
the people who can see a doctor 24/7, instant access. They're the VIPs of this foreign country.
Right.
Then you have tier 2, private insurance. You have choices, but you still have to worry about copays, networks. Tier 3 is government-sponsored Medicare and Medicaid. Here, your pool of providers shrinks drastically. Many doctors just won't take the insurance.
And then there's the bottom tier,
Yeah.
uninsured.
30+ million Americans. And this dictates everything about communication. As a nurse, you cannot just say, take this medication without knowing which tier your patient is in.
Because if you prescribe a tier 1 medication to a tier 4 patient,
You are setting them up to fail. The text mentions this really powerful point about the culture of insurance. What happens when there is a cure, but the insurance won't cover it? The provider knows the treatment exists, the patient needs it, but the culture of economics denies it.
that puts the nurse in such a terrible position. You want to be the caregiver, but you end up being the bearer of bad news from the economic culture.
And think about the emergency department dilemma mentioned in the text. This is a huge source of conflict that every nursing student will see in their ER rotation. The uninsured often have zero access to preventative care.
No primary doctor.
So where do they go for a toothache or a sore throat?
The ER, because the ER can't turn them away.
Exactly. So you have a non-acute issue clogging up an acute care system. And what's the result? 2-3 hour wait times. The staff is frustrated because they're there for heart attacks and traumas, not toothaches. The patient is frustrated because they've been waiting for hours in pain.
And that frustration just destroys the relationship before the nurse even says hello.
It does. The text notes that this leads to a complete breakdown in trust. The patient feels neglected, and the provider feels misused. It's a systemic cultural clash playing out in real time in the waiting room.
So, okay, we've established that this is a mess. We have language barriers, identity crises, economic walls. If you're a nursing student listening to this, you might be thinking, great, thanks for the anxiety.
Right.
But we need to pivot to solutions.
Yes. The text is very clear on this. The burden is on the provider to bridge the gap.
That's a key point. The patient is the tourist. You are the guide. You speak the language, they don't. It's on you to translate.
Precisely. So let's look at some actionable tactics. First, assess health literacy. Do not assume.
The text suggests a specific technique, the teach-back method.
This is the gold standard. Do not just say, do you understand? Because everyone says yes to that. They don't want to look stupid in front of the professional.
Sure.
Instead, ask them, in your own words, can you tell me what the plan is when you get home?
That immediately highlights the gaps. If they can't explain it, they didn't get it.
Second strategy, clarify roles. This is so simple but so huge. Patients do not know the difference between an RN, an LPN, a PA, or an ARNP.
To them, it's just a parade of people in scrubs poking them.
Exactly, and that creates anxiety. Who's in charge of me? Explaining, hi, I'm your nurse. I'll be with you for the next 12 hours, and the doctor will come in later to discuss the surgery. That builds immediate trust. It maps out the territory for the tourist.
Okay, what about the economic frustration? As a nurse, you can't fix the insurance company. You can't make the drugs cheaper.
No, you can't. But the text emphasizes empathic listening. Even if you cannot change the cost of the drug, validating the frustration matters.
Oh,
So saying, I know this system is incredibly frustrating and it makes no sense that this costs so much, actually aligns you with the patient. It makes you an ally, not just an agent of the system.
And finally, the language barrier. The literal one.
Use professional translators. The text is adamant about this. Do not use family members.
Oh, I have seen this happen. A kid translating for their grandma.
It's incredibly risky. First, the kid might not know the medical words. I mean, how do you explain colonoscopy if you're 12?
Right.
And second, culturally, they might not want to tell their grandma bad news. Or the grandma might not want to mention embarrassing symptoms in front of her grandson. Professional translation is part of the standard of care in this culture. Use it.
So let's bring this all back home. If you're a nursing student, you are in the middle of a massive transition. You are gaining power, you're gaining status, you are learning a new language.
You're becoming a citizen of healthcare. And that is a beautiful thing. It allows you to save lives. It allows you to intervene when things go wrong. But you have to remember that your patients are not citizens. They are visitors.
Frightened, confused, overwhelmed visitors.
Often, yes.
So your job isn't just to know the science. Your job is to be the translator. You're the one who stands between the biomedical machine and the human being in the bed.
Because you're training, that biopsychosocial model, it keeps you rooted in the human experience. You are the bridge.
I want to leave you with one thought to mull over as you head back to your flashcards. We talked about the white coat ceremony. We know how putting on that coat changes your identity.
Yeah.
It gives you authority. It makes you feel like a professional.
Well, think about the reverse.
Exactly. When a patient walks in, what do? We take away their clothes. We take away their wallet, their phone, their symbols of who they are.
Yeah.
And we make them put on that flimsy, open-backed hospital gown.
It strips them of their identity. It erases their status.
So the question is, when you walk into that room during your next clinical, are you treating the person who walked in the front door? Or are you treating the identity that the hospital gown created? Because if you can see the person under the gown, if you can speak their language, even while you're living in this foreign country of healthcare, you're already halfway to being an incredible nurse.
That is the goal.
That's it for this deep dive. Good luck with the studying. You've got this.
Go be a good guide.